When a patient like this undergoes transplant, and typically 3 months post-transplant, we'll do a bone marrow biopsy and do an assessment of their myeloma burden. And at that point in time is when we start them on maintenance-based therapy. The standard follow-up for maintenance-based therapy is really every 3-month assessment of myeloma proteins. It's more commonly or more often monthly, or sometimes every 4 to 6 weeks. We need to assess their CBC, we need to assess their other blood tests to make sure there is no organ toxicity. But in fact, the assessment of myeloma is really done every 3 months with laboratory testing. Now, some of these patients can relapse outside of the bone marrow, and I routinely will get a PET scan yearly in these patients post-transplant. So about 12 months post-transplant, they'll get a PET CT scan, and then typically we'll do it yearly. If it's somebody that's had extramedullary disease and maybe has relapsed mostly with extramedullary disease, then I follow the PET CTs more frequently, sometimes every 4 to 6 months. In the post-transplant setting, we've been now also assessing patients at their bone marrow biopsy at 3 months post-transplant and potentially at a year post-transplant with minimal residual disease testing, or MRD testing. Now, the benefit of MRD testing at the current time is it just tells us prognosis. It doesn't help us select therapy. It doesn't help us change therapy at the current time. It is merely a measure of prognosis. Those patients who are MRD negative do better than patients who are MRD positive. In fact, patients who are in complete remission that are MRD positive really do as well or do the same as patients who have just achieved a partial remission. So having a CR is only really good by a small amount of data that we have right now if you've achieved MRD negativity. Now, it's not quite ready for prime time. That's a problem. I think it will be several years before it's going to be ready for prime time for 2 reasons. One is the mechanism that we do to assess MRD is not available to all parties in the U.S., to all places and all practices in the U.S. There's 2 ways to do it. One is a Euroflow test, which looks at a 12-color flow cytometry test to really try to pick out 1 in a million or 1 in 10 times to the 5th cells. That Euroflow is only available at a few centers across the country at the current time. Over the next 2 years, it will be available more commonly at a lot of the transplant centers across the U.S., and doctors will be able to send samples from their patients. The other way to do it is by next generation sequencing or PCR testing. And there's a company, Adaptive Technologies, that's offering this test to patients with myeloma. And it requires having a baseline sample. And we don't have a baseline sample from their original bone marrow biopsy in everyone. In fact, we probably lose 20 to 30% of patients, of our ability to look at MRD through PCR testing because we don't have that initial PCR. Maybe in 2 or 3 years from now, it'll be routine that when somebody is newly diagnosed myeloma and gets a bone marrow biopsy, they'll have DNA sent for their DNA fingerprint of their myeloma, which looks at the immunoglobulin heavy chain and their light chain rearrangements.